I would like to speak on the bucket handle meniscal tear repairs. As we all know, menisci are a structure which are not having good blood supply. They are divided into three zones: the outer zone or the peripheral zone, which is also known as the red zone because it does have a good peripheral capillary plexus, like you see in this image. As you go on to the inner side, in the middle, you get the red white zone, which does have some vascularity, but not very good at it. But the inner zone, which is called white zone, does not have any vascularity. So if you have any tear in this region, they are not amenable to repairs. And even if you repair them, they do fail quite often. The bucket handle tears comprise of 10% of all meniscal tears. Fortunately, most of these tears are in red or red white zones and are commonly associated with the cruciate injuries. There are several factors which influence the success of the surgery when you repair the bucket handle tears of the menisci. Age of the patient, that is, if you have a degenerative meniscus in an elderly patient, it is less amenable to repair. If it's been a while and the patient has been walking on a torn medial meniscus or a bucket handle tear of the meniscus for a long time, the meniscal tissue quality does deteriorate. So these menisci are not very good to repair. The repair techniques vary from surgeon to surgeon. There are basically three techniques: the all inside repairs, the inside out repairs, and the outside in repairs. Most of the times, whenever you are repairing a bucket handle medial meniscus or tear of the lateral meniscus, you do have to use a combination of all these. If the patient has got any limb alignment issues such as varus or valgus alignment or malalignment, one needs to correct all these things simultaneously whenever you are going ahead with the repair of the surgery. A good rehab is extremely important whenever you are repairing the bucket handle medial meniscus tears. I'll present a case of mine. A 27-year-old male engineer presented while playing his domestic tournaments in a company. He had classical twisting injuries to the knee when fielding and presented to me with a locked knee and excruciating pain on day 0. On clinical examination, patient was holding his knee in 20 degrees of flexion and further extension of flexion were not possible. He had severe tenderness over the medial joint line. Fortunately, the lateral joint line was non-tender. The Lockman was negative. Other tests for instability could not be performed because of the pain. The X-rays were done, which show an incidental finding of an osteochondroma over the distal femur, it is on the medial femoral condyle. Because the knee was held in flexion, it was very difficult to comment about the joint space in this patient. The patient did not, however, had any sort of ligamentous evergent fractures. The MRI was the next step. One could appreciate in the coronal view here that the patient had a flipped and locked bucket handle tear of the medial meniscus in the intercondylar notch. The sagittal sections showed classical double PCL appearance, which is a pathognomic feature of locked bucket handle tear. The ACL, however, was normally seen. It is important to always check the axial image on the MRI in these patients. One could appreciate a locked tear of the medial bucket handle tear of the medial meniscus. If you have a lateral sided meniscal tears, it is important to know the position of the vasculature posteriorly so that you can plan your repairs accordingly. Diagnostic arthroscopy round showed that patient had almost grade 3 osteochondral defect on the inferior or the articular side of the patella. The medial meniscus was locked in the intercondylar notch and cruciate was normal. Pie crusting is a very important first step in meniscal repairs. The MCL could be pie crusted on two sides, on the femoral side as well as on the tibial side. I prefer to do these on the tibial side, as you could appreciate gradual opening so that one can get a good amount of space between the femur and the tibia so that you can push the meniscus back. It does help planning the repair and doing the repair as well. Probing the meniscus is important so that you can check for the peripheral zone tears of the meniscus. Like you can see here, the peripheral zone was highly vascular. Thus, this meniscus could be repaired back very nicely. Reduction of the meniscus is easily achieved if you have done good pie crusting with the limb held in extension or near extension with valgus force applied and the foot in external rotation. It is extremely important to check the tear extent so that you can plan your suture placement and number of sutures as well as your suture technique. In this patient, one could appreciate that the tear was extending right away up to the posterior horn of the medial meniscus, almost reaching the root of the medial meniscus, and then coming all the way forward from body to the anterior third, middle third junction of the medial meniscus here. Preparation of the meniscus comprises of 2-3 parts. One can use a shaver to debride the meniscal edges and remove whatever loose bands of the meniscal tissue you have. It helps in healing and proper approximation of the meniscus. It is important not to use the oscillating mode here for the shaver. You can use a forward or reverse direction of the shaver without any suctions attached to avoid any inadvertent injuries to the meniscal substance. You can also just debride the peripheral synovium around the meniscus, which increases the chances of healing. There are certain meniscal rasps available in the market from different companies, which are also used to prepare the sides of the menisci for the repair. Meniscal repair instruments and implants, which are commonly used, are these. I tend to use zone-specific cannulae for inside-out repairs. These have good curvatures ranging from 15 degrees to 45 degrees. These are meant specifically for specific zones. You could read on these zone-specific cannulae such as right posterior, right middle, right anterior, which suggest that the patient's meniscal zones could be repaired with these subsequent or specific cannulae. The inside-out menisci and middle are preloaded with a polybraided suture. You can have the sutures loaded with suture tape as well. Nowadays, I used it. It's a very nice implant, I would say. Or you can use several of these all inside meniscal repair devices from different companies. It is important when you're repairing the body or the middle third, anterior third junction of the meniscus to use the anteromedial portal as your viewing portal and anterolateral portal as your working portal, since the direction of the repair of the cannula for the inside out comes in a straight line. This is a very important stitch that is called the meniscus reduction stitch. These cannulae are so beautifully pre-bent so that you can go all the way beyond the medial femoral condyle without damaging the condyle or the cartilage, and subsequently passing the needle through that cannula for inside out meniscus repair. It is important to take the bite from the femoral side or the top capsular side first and then come down to the tibial or the inferior lip of the meniscus, so that once you have pushed this lip down and once you have tightened the suture, this reduction stitch holds the meniscus back nicely in the position, which helps your further repairs of the meniscus. This is a vertical mattress configuration. You can take subsequent vertical mattress configurations in similar fashion with the sutures spaced at least 3 to 5 millimeters away from each other for having a proper hold and proper positioning of the repair needles. The vertical mattress fashion for the medial meniscus or meniscal repairs is biomechanically much stronger since the repair is done perpendicular to the tear, but it has got a disadvantage, which you can see on the right side of the video side, that the meniscus tends to sit up or get inverted a bit if you have put the vertical mattress sutures. Hence, it is extremely important to pull this meniscus down to the tibial side. This could be achieved by taking horizontal mattress kind of a suture configuration on the inferior aspect of the meniscus, as one can see on the right sided video. Whenever you are pulling the inferior stitch, it is very nicely seen that the meniscus just sits back on the tibial side. Like here. It is also easy to repair the middle and anterior zone repairs using the same inside-out cannula system. Since the cannulae are pre-bent accordingly, like you can appreciate here, my cannula is easily reaching the anterior and middle third junction. If you do not have these cannulae, you can use the you can use the outside in repair system or use spinal needles for the same. It is important to reach all the way up to the edge of the meniscal tear and put a vertical mattress suture there to prevent any further progression of the tear here. The all inside devices could be used again for the posterior sided repairs of the menisci. I tend to use it on the posterior side to prevent any inadvertent vascular injuries. One has to use a slotted cannula first, over which the all inside device just passes. It is important to hold the device with the angle facing inferiorly when you pass it to avoid any chondral injuries to the femoral condyle. One has to measure the depth of the meniscus and set the depth mark accordingly before passing these devices. I usually tend to use 18 millimeters as the depth for these menisci repair devices. As you would appreciate here, as you go on tightening these sutures, one has to be careful that you don't over tension it. You can use a hook probe just to push the meniscal substance down when you are tightening these. As you pull the suture, the meniscus tends to sit up and get inverted. So it is imperative to put another meniscal stitch on the inferior aspect of the meniscus to pull the meniscus down. As soon as you tighten the stitch, there you can see it. Final repair after knot tying will be like this. For this large meniscal tear, I would use at least 8 or 9 sutures for the meniscal repair. There are certain things which will help meniscus to heal. One of them is doing a microfracture in the notch, just anterior and superior to the ACL attachment. These microfractures, when done, help to bring the healing substituents inside the knee, thus helping the menisci to heal. Rehabilitation for these patients, I keep the patients non-weight bearing for 4 weeks and allow knee range from 0 to 60 degrees. Certain surgeons would allow 0 to 90 degrees of knee flexion. If you have a huge meniscus tear, I would avoid it, since there are certain studies which show that the tibiofemoral contact pressures increase a lot if your knee goes beyond 60 degrees of flexion. So I tend to be safer when doing a rehab for these patients. The gym protocol starts at 3 months and the sporting activities after 8 months. When you have to avoid complication with these repairs, patient selection, as I had already mentioned, has to be critical. Try and avoid these repairs in degenerative menisci. Meniscal reduction has to be proper. So is the meniscus preparation. Spacing of the sutures has to be proper. All the sutures must be spaced nicely, at least 3 to 5 millimeters gap in between the 2 sutures. Type of sutures. If you are using a monofilamentous suture, there are higher chances of it cutting through the meniscal substance. So braided polyester sutures are preferred. The direction of the needles has to be slightly inferiorly directed to avoid any neurovascular injuries. And always take safety incisions before you start putting these needles. If a patient has got associated injuries, such as this patient had an ACL injury associated with a bucket handle tear, then you can go ahead and repair these menisci nicely. Put the meniscal sutures first. Do not tie them down. Do your ACL or cruciate reconstructions. And for the medial sided injuries, you can tie these sutures with the knee in extension or almost an extension or 10 to 20 degrees of flexion. For the lateral sided suture tying, you can tie these sutures in 60 to 70 degrees of knee flexion. If you do not tie the medial sided sutures, it's like almost full extension, there are higher chances that you will imbricate the posterior medial capsule, and this will lead to a fixed flexion deformity post repair. Arthropfibrosis, that is the same thing. Failure of repairs is also common, especially if you are using a monofilamentous suture or putting too much of tension when putting your sutures or stitches. Needle stick injuries, if you take good care, will not happen in these patients. I thank you again for having me here for the talk. Thanks a lot, everybody.